Hello, everyone from around the world. My name is Lucy King. I'm with the international NGO Interburns. It's an honor to welcome you to day 4 of World Burns Week, the global webinar series. I'm just going to run through some instructions for translating for this session. If you'd just like to look at this screen, you can activate auto-translated captions by toggling the translation button. The speaking language is English, and you can choose your own language. I'll give you a few seconds to do that. Thank you. World Burns Week is an initiative to advocate and bring together all those, whether individual or organizational, healthcare workers, survivors, or legislators, to shine a light on the importance of improving burn prevention and care, especially in low-resource settings. The theme of this day is preventing the chaos of mass casualty burn disasters, and it's especially relevant. As you can see, World Burns Week has been running throughout this week every day with 2 time slots. And we enthusiastically urge you to go back and listen to some of those webinars that you missed and to follow us. And we're delighted that you joined us today for time slot A. There'll be another webinar, time slot B, with different speakers at 1 a.m. GMT. We're delighted today to have speakers with first-hand experience in witnessing, managing, and planning for such mass casualty burn disasters that happen all too often in low-resource settings, where the systems are not developed to manage them. Dr. Ethel Andrews will just give you an introduction. Ethel is the first nurse to have a PhD in burns in South Africa, the first nurse to be a representative on the Pan-African Burn Society, the first non-surgeon to be elected as the president of the South Africa Burn Society. She's a member of the International Society for Burn Injuries and is on the editorial board of the Burns Open Journal. Ethel has worked consistently to build networks, promote nursing, and be a change leader. She joins us today from South Africa, where she's representing the Pan-African Burn Society. Thank you, Ethel.
A burn can happen to anyone at any time. It does not discriminate against age or gender or even race. It does not discriminate against your social status or even your economic standing. Likewise, a burn disaster can happen to anyone at any time. This session will be on preventing the chaos of mass casualty disasters, where a failure to plan can mean planning to fail. A burn disaster has been described as a burn event that overwhelms the local healthcare system's capacity. We have witnessed more and more of these happening in recent years, with plane crashes, hijacked buildings, gas tanker explosions, informal settlements going up in flames, and even wars and conflict. In South Africa, we have also had our fair share of burn disasters. Allow me to share some recent footage of a burn disaster we had.
Overseas tonight, one of the deadliest fires in South Africa's history. At least 74 people, including 12 children, killed overnight in Johannesburg when a fire tore through a building where homeless families and squatters were taking shelter from the winter cold. Here's ABC's James Longman.
Tonight, the raging inferno ripping through this 5-story building in Johannesburg. People jumping from the building to escape. Witnesses say babies were thrown from windows.
It's the window and we brought the dog outside.
40 bags lining the street, 12 children among the more than 70 people killed. Firefighters searching through the smoldering rubble for remains. Authorities say dozens of people were trapped behind locked security gates. And according to one witness, there was only a single exit. The actual fire escape was closed. Central Johannesburg was once a
Having a disaster plan in place means adequate triage and prioritization. It means preservation of resources and logistics management. It also means having prepared staff, being able to deliver competent and standardized care. The absence of a plan, on the other hand, means panic and chaos. I would like to pose a question to you. Can we ethically afford not to have a plan? Because the reality is poverty and inequality is not going to disappear overnight. Neither are wars and conflict. Human error can't always be avoided. And what about acts of God? In the words of Benjamin Franklin, if we fail to plan, the reality is we are planning to fail. This session will be addressed by various experts in the field of burns who have dedicated their lives and have been committed to dealing with burn disasters at various scales. I would like to hand over to them, and it is a huge honor to be able to participate in such a very important discussion. Thank you.
Thank you so much, Ethel, for that introduction. We'd like to welcome questions from any of you watching today to our experts. And at the end of the session, we will have a 5 to 10 minute Q&A session. So please, when you're writing your questions, use the Q&A function at the bottom of your screen, and we will pose those towards the end of the session. I'd like now to welcome Richard Nabuka, who's unfortunately not able to be here today, but he has sent us a video telling us about the impact of burn disasters. Richard is from Nigeria. He's a plastic surgeon. He was previously president of the Pan-African Burn Society. He's a trustee of Interburns and was a member of the WHO Technical Working Group on Emergency Medical Teams in Burns. And he's a trainer in burns and plastic surgery for the West Africa College of Surgeons and the National Postgraduate Medical College of Nigeria. Thank you.
Hello. Welcome once again to the World Burns Week 2025. My name is Richard E. Nabuko, consultant burns and plastic surgery from Nigeria. And I'll be talking on immediate impact and fallout, what happened, what went wrong. And this will be the presentation of a case study from the 16th October 2025 tanker explosion from Majia, a town in Jigawa State of Nigeria. Disaster is what happens when hazard meets unpreparedness. And this was clearly shown from the Jigawa fire. These pictures are not rare freaks. They are repeating system failures across sub-Saharan African nations. The first 2 hours decide survival, and yet that's when chaos peaks. Sub-Saharan Africa averages about 20 major petroleum-related fires yearly, and these are often from overturned tankers or depot explosions. That's usually triple the number of hospitalized survivors, and the usual trend is there is an immediate chaos, crowds gather, there is a fuel ignition, and because of poor triage, the hospitals are overwhelmed. This was the case in Majia, Jigawa State, 16th October 2024. A tanker overturned on the Majia-Kano highway. Villagers gathered to scoop spilled fuel. An explosion occurred about 8 a.m. And within an hour, 209 people had been found dead, dozens severely burned. 210 families were affected by the explosion, and property damage costs worth millions of naira was recorded. Hospitals in Hadejia and Dusse, which were two big towns close to Majia, were overwhelmed within the first hour. And survivors, again, were evacuated without triage and without burn care supplies. This is a timeline of exactly what happens. Overturn, scooping, ignition, explosion, hospital influx. In 30 minutes, a small town became a battlefield of fire and screams. Each missed step multiplied mortality and caregiver burnout. What happened in the first hours? There was no crowd control, so new victims were added. There were no pre-alerts to hospitals, and so no arrangement was made for those that arrived at the hospital. Ambulances and pickup trucks were used to transport many of the injured without any attention to airway management. Burns covering 40 to 90% total body surface area were all evacuated. And this, of course, led to inadequate IV fluids, dressings, oxygen in the hospitals. And within 4 hours, the hospitals ran out of supplies. Again, this is the process slide. Scene chaos, leading to delayed evacuation, overwhelmed ED, leading to resource exhaustion. On this chart, the points on the left, which we call the failure node, show exactly the impact in the hospitals or in the impact in the various centers. So this is a picture of systemic failure. Scene control was absent, and so explosion casualties multiplied. No pre-hospital coordination, and so in such rescued patients, airway and shock management was impossible. Because of poor triage and such plan, there was a mixture of critical and moderate burns. Because of poor resource in the end hospitals, fluids, dressings, ventilators were not available. Poor communication also led to an unprepared hospital and duplication of efforts. This is not an isolated case. We've seen this across sub-Saharan Africa. 2019 was the Morogoro, Tanzania incident involving an overturned tanker with 69 deaths. 2021 in Wellington, Sierra Leone, 131 deaths. Boksburg in South Africa, 2022, 40 deaths. Totota, Bank County, Liberia in 2023, 40 deaths. And most of these cases involve multiple fuel scoop fires. So different countries show different early chaos, an absence of preparedness, control, triage, and communication. Beyond the flames, what were the invisible aftermaths? These were psychological, were physical, and they were systemic. Survivors with severe infections, graft failure, PTSD were much later, excuse me. Families were impoverished because local facilities were all paralyzed. Surgeons working 48 to 72 hours marathon suffered severe fatigue. Of course, the public will blame the system, whereas they were also part of the contributory factors. Preparedness isn't theory, it's logistics rehearsed. And that is the only way you will break the chain of chaos. Preventive systems that could have changed the outcome were not in place. Scene cordon with police and fire coordination within 10 minutes of the blaze was absent. EMS pre-alert and tiered evacuation to nearest burn-ready centers was lacking. There was no disaster plan, and so there was none to activate. Stockpiled burn kits, IV fluids, airway carts were all exhausted. Multi-agency communication link, which will involve the Federal Road Safety and the Federal Ministry of Health, was totally absent. And so there was no coordination in a situation like this. Preparedness saves lives before the siren sounds. And we have to move in sub-Saharan Africa. We have to move from chaos to coordination. Chaos is inevitable. It is the result of unpreparedness. And so every state in Nigeria and indeed in SSA must have a burn disaster response plan. We should be able to train our responders. We should be able to stock supplies and link hospitals. The goal is to turn chaos into coordinated response. The framework for preventing chaos should be a preparedness plan that is built bottom up. It's not one that should be improvised in chaos. The public awareness and prevention should have been in place, and it is not in place in many of our countries. The first responder and fire service readiness, again, is lacking. Hospital surge and burn capacity should be worked on. And all of this national coordination and policy is something that should be taken up by the federal ministries of health and transport in the various countries of our region. Sadly enough, this is not happening yet. Well, some countries have tried to build some form of coordinated response, but we find that events like this still overwhelm whatever resources we have. So it is possible to move from chaos to preparedness. It will take time, but we hope we will get there. So I wish you all a burn-free week, and thank you very much for listening.
Thank you so much, Richard, for that presentation. Very somber, but it is also the reality that most low-income countries are facing. I like what you said when you said that each misstep multiplies the mortality as we experience it. Next, I would like to introduce you to Nikki Alotto, who is a general surgeon with critical care training in South Africa, Pietermaritzburg. She is involved in all aspects of burn care, from research and teaching, resource management, surgery, outreach, and telemedicine. Nikki has developed multiple databases and apps for burns and has a passion for getting the basics right, being practical in the development of its service. Welcome, Nikki.
Good day, ladies and gentlemen. Welcome to World Burn Week. My name is Nikki Alotto, and I'm a South African burn surgeon, and I'm going to present to you triage as a novel concept for guiding burn care in low-resource settings. Triage has typically been described in mass casualty incidents, and mass casualty incidents are defined as a sudden surge in patients that overwhelm the capacity of the local medical resources and often result in preventable mortality and morbidity, typically around natural disasters, violence, or road traffic accidents. It leads to challenges in the clinical service delivery, particularly in those with resource-limited settings. What is triage itself? This is the sorting of and allocation of treatment according to a system of priorities designed to maximize the number of survivors. Or it can be considered as the assigning of priority order based on where funds and other resources can best be used, are mostly needed, and are most likely to achieve success, which I think is very important. And there's much literature describing the need for triage in mass casualty incidents. But what about thinking of triage in a different way and using it in a low resource setting, particularly because we have a high burden to resource ratio, and it's an ongoing challenge with insufficient beds, expertise, as well as insufficient equipment and consumables that are needed to treat burn injuries. Priority systems have been described by the Committee on Crisis Standards of Care as a systematic approach aimed to select patients to be prioritized for intervention, and again based on a more urgent need and greater potential benefit for the patient. Crisis standards of care are defined as a substantial change in the usual healthcare operations and the level of care that it is possible to deliver, and it is typically justified by specific circumstances and formally declared by a state government in recognition that a crisis has occurred and that operations will be in effect for a sustained period of time. But what about low resource settings? We experience not a change in care that was previously delivered, but rather experience that the crisis is ongoing with a high burden of injury and low resource access. We have recently published on this topic and attempted to provide a framework for management of care delivery in a resource-restricted service, specifically focusing on access to surgery for burn-injured patients, and our study aimed to describe the efficacy of this prioritization system, where the primary outcome was the ability to perform surgery in the priority group of patients within 3 days of the decision. What did we prioritize? And there were 3. So one criteria for priority surgery was large surface area burns. This was specifically deep burns, more than 15% total body surface area, and we felt the need for early surgery was in the attainment of physiological source control. Our second priority was invasive burn wound infection as part of sepsis source control, and the third criteria was a full thickness or 4th degree component burn of the hand, foot, or limb, where there was high risk of limb loss or significant deformity or dysfunction if not operated on early. However, priority criteria may not only be linked to the need for surgery, but can also be linked to the need for ICU or the need for transfer to a burn unit or a burn service. In Pietermaritzburg, 94% of our referrals meet the standard national transfer criteria as you've seen here, and these transfer criteria come from high-income country settings. To manage that burden, we have implemented tools, particularly the Vula Medical Referral app, that allows us to communicate with our referral area, which is 3 million people, and using that application to facilitate appropriate transfer to the Pietermaritzburg Burn Service rather than a blanket transfer of everybody that meets standard criteria. For example, this is a hand burn. It would meet the criteria of a special area burn, but is actually quite minor. It's small in surface area, it's superficial partial that should heal, and in conjunction with specialist discussion can be successfully managed at a district level care or a clinic level care. And this is just an example of how we use the Vula app as a tool in order to provide appropriate triage of our patients. We must be cognizant that selecting the criteria for triage and priority will be dependent on local capacity, and that might include beds, it might include expertise such as the surgeon, nursing, the anaesthetist or the rehabilitation team, theatre time, access to ICU, and access to blood and certain equipment. And it is important to understand the local thresholds. Take, for example, a massive full-thickness burn injury in a small child. And part of triage for low-resource settings should include a robust palliative care policy, remembering that the thresholds for the institution of palliative care will be different in low-resource settings. And the threshold, what is defined as a massive surface area injury, or where age would determine survivability, and of course inhalation injury, we must be cognizant of survival, and that where survival is unlikely, we should be instituting palliative care. And we need to be realistic, and in deep burns, the donor site availability and ability to graft timeously should be a major consideration when determining palliative care policy. In conclusion, global standards of care for burn injuries are desirable, but not always possible. And we need to use the concept of triage in a novel way in order to provide or manage our limited resources, which may include access to surgical care, It may mean using triage for referral to a higher level of care or for the institution of palliative care, remembering that local context is extremely important. Thank you.
Thank you so much, Nikki, for an informative, practical, and realistic presentation. Next, I would also just like to remind the audience to please use the Q&A if you have any questions available to any of our panelists. It's my honor to introduce to you Stian. Stian works at the Norwegian National Burn Center in the Department of Plastic Hand and Reconstructive Surgery. Stian is also head of the research group for burns care and reconstructive surgery at the University of Bergen, where they research burns and reconstructive strategies, as well as epidemiology and mass casualty management. He's the co-chair of WHO's Emergency Medical Team's Technical Working Group developing recommendations for burns in mass casualty disasters. Welcome, Stian.
Thank you very much, Ethel, for this really nice introduction. My presentation now is relying on huge collaboration work from different organizations. That's what I'm showcasing, different organization logos on this first slide, because preparedness work is never a single man job or a single organization job. Well, just to start what I'm going to talk about. Well, we know that burn disasters, mass casualty incidents do happen all over the world. But as with all other burn care, the distribution is not even. The heavier burden is on the low and middle income countries in the world, but these things do happen all across the world. And the number of victims are from large incidents with only burns, but also there are war zone incidents where there's a constant, over a long time, a constant stream of victims, like in Europe now, in Ukraine and all of the war areas of the world, where the victims are not simply burn patients, but often in combination with other trauma. To take some examples from our continent, we saw some examples from the other speakers. So in the European continent, there was the Nagorno-Karabakh incident in 2023, creating hundreds of burns and gas tank explosion, hurting refugees, with the need for international assistance at that point. Also in Romania, there was a gas tank explosion in 2023 also. With a lot of incidents, with a lot of injured. But in this incident, there was actually quite a huge display of international effort, and the European burn plan was put into use, and patients were distributed around Europe. Also, there was an burn disaster in North Macedonia in March of this year, where the EU plan was activated and patients were transported to neighboring countries via bilateral agreements and via the EU system in the few days after the incident. And when Hel talks about disaster planning of the last years, I've tried to ask this question to the audience. You know, if a friend of yours calls from another country and says, well, we need urgent help, there's been this huge disaster, can you please come help us? Would you act? And I think most people in the audience in different settings do raise their hands for this, and because we are, as doctors, so eager to put our efforts to use and be of help. But what we oftentimes tend to forget is that it is not just our expertise or our skills that are needed. We also need an area to do that healthcare. A hospital setting, and we need a steady stream of supplies to be able to do what we think we can do to help. And that needs planning, like previous speakers said. And actually, if you look at this is an image from the border between Poland and Ukraine in March 2022, a few weeks after the war started, where there was this enormous willingness or good intention in Europe to send supplies, but there was no chain of logistics to distribute these supplies, so they ended up as huge piles of waste on the border. And also on the medical side, the Haiti earthquake in 2010 really taught the world a lesson, and there was a lot of papers written after that incident about how this event almost became disaster tourism, where people went there to help but were not able to, when unplanned teams performed redundant assessments, that just a lack of coordinated efforts, and in some instances even competitive humanitarianism, meaning that the teams wanted to be the first one to deliver their care. And obviously this was not good, and this actually was the start of what we all now know as the World Health Organization's EMT initiative, led by Ian Norton for many years, which makes standardized training for teams to deliver healthcare in emergency supports and in support of the local health system. So there's a system built. And also for burns, there has been the working group that some of us participated in, and also an academic paper around that, and also standards for burn care and mass casualty incidents, and that's worth visiting. If you haven't seen these before, these are good guidelines that are supposed to be helpful in making planning all around the world. I'll tell you shortly a little bit about the story of in Europe. We needed a large incident to wake us up. So in 2015, there was a large burn incident in Bucharest, Romania. Many injured, and not a system in place in Europe to be able to help. So Romanian authorities couldn't just push a button and say, Europe, please help us. And that's really sparked the start of the work on burns planning in Europe. And fortunately, Europe had since 2001 a system of providing aid in crisis, but more in civil protection incidences like forest fires or flood events. But they were planning already in 2015 to implement the medical part of it. So the healthcare response was being built, and burns was one of the areas. But as previous speakers told you, this planning is careful. It needs careful planning. It takes time, and so it took 5 years from the initial start-up meeting until before the first plan was approved in writing, and it's still ongoing work in Europe. The system we built in Europe is that there's these three resources that are supposedly available in a burns crisis. That is burns experts. We know from what Richard told us that the enormous resource demand of these large-scale incidents overwhelm local hospitals. So we know also that burn care is one of the most resource demanding areas of healthcare. And to be able to sort and prioritize and do what Nikki told us about, do a good triage, we need people knowledgeable in burn care to be able to sort out the priorities. And then we need healthcare facilities to send patients to, whether that is within your country, within the city, or internationally even. One needs to establish these places where burn patients can end up. And we need the capacities to transport them there. So a core part then of the European burn plan is the burn assessment teams. So they're supposed to be teams of experts that can be sent out to help assess patients and assist local authorities. And their main purpose is to define definitive care needs for the patients and medevac priorities of the patients. And then national plan or a local plan even will need to have this aim to be able to make decisions early on the definitive care levels for patients, because we have this window of opportunity right after the resuscitation phase, before the complications or infections come in. There's a window of opportunity where we actually can do redistribution of patients, and the local surge plans of any hospital or any national system should aim at getting definitive triage within these first few days. And the recommendation is that each country, or starting from the local hospital up to the regional, or then later to the national, international level, one needs to define thresholds of activation. What's our capacity? What's our capacity, surge capacity for being able to care for patients, stabilize patients for 3-4 days? What is our ultimate treatment capacity? When will we need to ask for help from our neighboring centers? When will we need to transfer patients? And all these things need to be predefined so everyone knows them. And we need to have procedures for activation at each level, and to create a culture of what we call no regrets, so that people are not afraid of activating because there might be costs occurring, or being afraid of making decisions. We should establish a culture where do activate and then de-escalate if needed. It's better. It's always slower to you lose time and you lose patience if you wait. And then we need to know, how do we request, and also the local and national plans need to describe how do we receive help. So if we ask for help, how can we integrate that help, and how does that play out in our system? So you build the local response before the national response, which then comes to maybe a bilateral response, like we have a Nordic agreement in Northern Europe, and an international response, such as the European plan. So it starts from bottom up, like Richard also told you. And the specialized in hospital triage is super important, because patients do distribute themselves in the beginning by private cars, they are as walking wounded, even with quite large burns in the first few hours, and we need the teams to go around and make assessments and priorities. And these assessment teams should be trained and predefined, and there should be communications strategies for how to communicate the triage results and the data gathered by the team. And they should have clear roles and responsibilities. In Europe, we've had training of teams, 25 teams around Europe at the moment, and hopefully more in the future years. Also, I think this is quite important to be aware of, that this willingness that we all have to act and to help should be put into plans and systems. And by training it and by talking about it to authorities and all levels in the hospital, we create visibility, and that visibility can then create political support, which is needed to implement it on a national level, also especially on an international level. You need to create some support for your plan and create a public willingness to act and to prioritize doing this preparatory work, which this is an ongoing circle, always improving the plan. So coming back to, would you act? Well, the way we should act is to think that we should prepare to act. So we should focus on local and national planning. We should train as we plan, and we should create teams that can do this on a short time frame and save lives. And burns associations like the EBA and the ISBI and Interburns, they should all serve as resource hubs for preparedness planning, and disseminate good practice in mass casualty situations, and encourage individuals to not self-deploy, but be part of a system. And I would like to close with these words from Tan and von Treb. which said that the standards we should strive for in emergency care international responses is accountability, empowerment of local autonomy, and the optimal position, being in the optimal position to do the greatest good by our planning and to meet expectations and be liable. And if you'd like to look into the more of details of the European planning, this is available as open access publications. Thank you.
Thank you so much, Stian, for that very comprehensive overview of the need for coordination and planning, but planning takes time. The need to focus on staff, spaces, and supplies, and for pointing us all towards the examples such as the European example and the WHO recommendations, which are all freely available. I'd like to hand you over now to Tom Potakar. Tom was formerly Chief Surgeon at the International Committee of the Red Cross and a Professor of Global Burn Injury at the Centre for Global Burn Injury Policy and Research at Swansea University. He's worked in the international field since 1990 with MSF in Cambodia, Bosnia, Tajikistan, and Rwanda. He was co-chair of the WHO EMT Technical Working Group on Burns. He co-founded Interburns, for which he has led programs in many countries, including Afghanistan, Nepal, India, Bangladesh, Ghana, Lebanon, and the occupied Palestinian territories. Thank you very much, Tom.
Good afternoon, everybody, and welcome to this webinar. You've been hearing earlier on about the preparations for how to cope with a mass burn casualty, and particularly around creating a plan, which is a vital step in the process. I'd like to now move on a little bit from that and talk about, okay, so now you have a plan, now what? So I'm imagining, as I'm sure many of you have, you're busy in your office or in the emergency department, and somewhere stored on a cupboard or a shelf, along with lots of other policies and guidelines, you will have a plan. Like here we have the plan for the management and standards and recommendations for burn care in mass casualty incidents. So this is a really important first step. And of course, that plan may be one that already exists, like these ones from the World Health Organization, or it may be based on these, or you may have created one yourselves with your team, etc. So this is a really critical first step. But of course, a plan sitting in a folder on a shelf somewhere does not get you where you're needed. So in any mass casualty situation, the critical part is, are the following people all aware not only of what they need to do, but are they actually able to do it? And as you can see, in a mass casualty scenario, it's not just the clinicians, but there's many other people involved in the management and in the excuse me, preparation and in dealing with such an incident. So once you have your plan, you then need to ensure that all these people that may contribute and be a part of it actually know what to do. So this may include clinical staff, as I say, but also non-clinical staff, administrative staff, management staff, coordinators, etc., etc. So they need to know what to do, but more importantly, they then need to actually do it. And another way of putting this is they need to have the knowledge, but then the knowledge on its own is not enough. That then has to be followed by action. So in order to undertake this process, we need to think about what's called dissemination and implementation. So dissemination is the process by which something is communicated in a way that can facilitate understanding and use. So with respect to the mass casualty plan, this means making sure that the right people understand what is in that mass casualty plan, and that they are aware of it, and they have read it, and they understand it, and how to use it. The implementation side is the processes by which many things, such as guidelines, recommendations, policies, etc., are incorporated into use. So one of these is around letting people have the information. The other is then around putting that knowledge, that information they have, into action. So it's a process that goes through informing and then takes what we know and turns it into what we do. Now, one way of looking at this is the knowledge to action pipeline. Now, this is a really important step that allows us to understand where there can be blockages and problems to the implementation process. So in this, the first step is, are people aware? So in the case of a Burns mass casualty plan, are they aware that it actually exists? Have they seen it? Do they know where to find it? Secondly, do they accept it? So they may be aware it exists, but they may not accept what's written in it. Is it applicable to them? So some people may read it, but actually they're not going to be any part of it, whereas others, it will be something that is extremely applicable to them and relevant to them. Are they able to actually act on it? So this is around, are the resources there? They may be aware of it, they may accept it, it may be relevant and applicable to them, but they're not able to do it because they don't have the appropriate resources. With all that, do they then actually act on it? So this is the part, do they actually then follow what is in this plan when a mass casualty event happens? Once it has happened, and then there's a review process, etc., do they agree that what went on was appropriate, was good? Are there lessons to learn? Do they agree that it's a good framework for the performance in a mass casualty event? And then the final step is around sustainability, and will they adhere to this in the future? So this knowledge to action pipeline can be used in many, many different scenarios. And one that I think is very pertinent, for example, is hand washing. So we know that hand washing causes, or rather prevents, a huge amount of complications globally in healthcare, and yet it is still not taken up 100%. And you know, many places, as I'm sure you've all seen and are aware of, people do not use hand washing as it should be before and after clinical interventions, where it should be 100% implemented, but we know that it isn't. So if we look at this process here, you know, most people are aware that hand washing is important, and most people do actually accept it. And if not, this is around a knowledge part of the pipeline. It's far more applicable, obviously, to doctors and nurses than it is perhaps to secretaries or managers who have less interaction. So it's important that those that it's applicable to are aware of it. Now, then we start to get to the more difficult parts. Are people able to do it? Well, sometimes there's problems with lack of water, lack of soap, lack of alcohol gel, etc., which means they may be aware, they may accept it, it may be applicable to them, but they're not able to do it. Or maybe they are able to do it, but they just don't do it. And now we're moving into more the disciplinary side of things. So as you see at the far left of this, it's more around knowledge. In the middle, it's more around quality improvement. And to the far right, it's more around actually just disciplinary matters. So let's quickly mention what we mean by a dissemination strategy. So this can be either general or targeted, or a combination. So do you tell everybody everything, or do you focus on specific groups and give each group what they need to know, but nothing more, or a combination of both? You need to engage all the stakeholders, establish processes and materials, delegate specific tasks, and set a deadline. And if we look particularly at establishing processes and materials, this will be around different ways that can be done. It can be through compulsory training. It could be through disseminating a monthly meeting every month over a period of 6 months, or done 3 times a year and repeated every year 3 times. It could be through posters in various places, action cards, a mobile phone app, email. It could be linked to performance review, or even linked to a social event. So there's a lot of different ways that we can look at for actually disseminating the knowledge and the information. What then about the implementation strategy? Again, one good framework for looking at this is called the Framework for Implementation Research. And this talks about the innovation. So that is the thing that needs to be implemented. So in this case, we're talking about the mass casualty plan. Then there's the inner setting. And this is the setting in which the innovation is implemented. So in this case, we're talking about hospital, pre-hospital, emergency room, operating theatre, wards, etc. The outer setting is the wider environment, so the health system, transport, communications, finance, etc. And then the individuals, this is around the roles and the characteristics of the individuals involved in this plan. So those that are actually going to be acting on this plan. And then the process is the activities that are used to implement the innovation. So it's a useful framework to look at these 5 different areas. And then when we think about what we want to achieve, it's really that the final step in the pathway is around behavior. It's around people having the knowledge and then acting on that. So that acting on that is their behavior. And there's a useful model for this called the BCOM, which talks about behavior being related to the capability or the capacity, the opportunity and the motivation. So for the capability, somebody has to have the knowledge, the training and the experience. So for example, if they've been asked to triage patients that are arriving in the casualty department, do they have the knowledge to do that? Have they been trained in it? And do they have some experience? And with those 3, they will have the capability to perform that task. The opportunity is around the resources and the personnel. So should a mass casualty event occur and they've been asked, for example, to triage, well, do they have the resources available? Are there enough personnel to do that job, considering the number of patients? How many staff do they have? And with those staff, do they have the appropriate resources? Do they have scissors to cut off clothing? Do they have stethoscopes to listen to the lungs? Do they have dressings to dress the patient after they've seen them, etc.? So do they have the opportunity? The opportunity is around the resources and the personnel, and can also be considered as the sort of physical requirements and the social requirements. Are they actually allowed to do what they've been tasked to do? And finally, the motivation. And motivation can either be intrinsic or extrinsic. And this is often the most difficult one, because people may have the capability and the opportunity, but when it comes to the actual action, it's around the motivation. So this is a particularly interesting area that has a significant impact on implementing any intervention. So again, engage stakeholders, use the knowledge to action pipeline to identify where the problems are. Is it because people are not aware? Is it because they don't agree? Is it because they don't feel it's relevant or they're not able to, etc.? And then target specific individuals or groups based on that analysis. Identify barriers and facilitators with processes, the inner and the outer setting. So not just those things that are immediately obvious, but also from the wider environment. What are potential barriers and facilitators to implementing this mass casualty plan? And then use a PDSA, a plan, do, study, act approach to try and engender continual improvement. So in the end, it's not about what you know, it's about what you know and, more importantly, what you actually do. Now, the real world scenario, of course, is very different. So if we look here, this is a typical scenario in a mass casualty when there's lots and lots of ambulance arriving, they're all backed up. It's difficult to get into the casualty. Patients may have been arriving in a completely different order from you were hoping they might arrive, and this can make life very difficult. It's also, in a real world scenario, things never quite go according to plan. There can often be disruption. So here again is a typical mass casualty event. And you can see here, this is by no means abnormal. You have lots of people, you have relatives, you have family, you have other staff, other people. And it's really important to accept that this is the real world. We have to understand that whilst those working in the hospital may have gone through training and understand the process for dealing with a mass casualty, those that are arriving and their families and relatives, they have not. So it's important to understand that and to not expect miracles, but just to do the best you can. And having a framework can at least provide a good springboard for doing that. But we have to accept that this is a real world scenario where the behavior of everybody else, it's difficult for us to influence that. and therefore things often don't go quite as we would hope they would go. So in summary, do you have a plan? Yes or no? If you don't develop a plan, then if you have that, are people aware of it? If they're not, you need to work on a dissemination strategy. If they are aware of it, do they actually know what to do? If they don't, then you need to develop the implementation strategy part. And then once that is done, you need to perform regular exercises and simulations to ensure that people don't forget, that they keep up to date, and to regularly check that each person knows what they need to do in the specific environment of a burn mass casualty scenario. So I hope that's just given a little indication as to how you need to think beyond the plan itself, but to the actual implementation of that. Hopefully you won't have to face a burn mass casualty, but if you do, I hope some of the talks today will help you cope with it. Thank you very much.
Thank you so much, Tom, for a very educational and practical presentation. I would like to invite you and Stian to turn on your cameras as we go into the question and answer session. So the first question, Tom, would be directed to you based on your last statement during your presentation about prevention. So Anonymous was asking that while talking about preventing the chaos of mass casualties, are they preventable in the first place? And what are your thoughts on our role in addressing the root cause, such as war, poverty, and fire safety?
Yes, thank you very much for that question. And clearly, as we all know, prevention is better than cure. So I think that's very, very important. Now, this is really more around the sort of global development, politics, and financing, frankly. Most, as Richard pointed out in the first presentation, you know, there's far more fire disasters in the poorer countries around the world, and this is for a whole host of reasons, including legislation, including just poverty, the fact that people, when there's, for example, a petrol tanker spill, rush there to get petrol because, you know, it's going to be free for them and they've got very little money. So these are things that I think it's a much more kind of structural problem, if you like. And the same with when we see garment factory fires in Southeast Asia, for example. Prevention is absolutely what's needed. And in order to do that, I think we can have a role in the sense by advocates, by emphasizing, by working with government at government level to try and increase awareness about these disasters and work with them to try and help them to devise preventative strategies. So I think we can do some things. In terms of war, that's a much more difficult one. But as healthcare professionals, yes, I still think even within that very, very difficult environment, you could say, well, how can a nurse, a doctor, a therapist do anything to prevent war? But I think, you know, healthcare professionals are still widely respected across the globe, and we are listened to. So again, I think it's around advocacy, frankly, and war has so many huge impacts on healthcare, not just obviously burn injuries, although recent conflicts, they have been a very significant part of it. So I do think our main role is in advocacy, is increasing awareness and working with the people who can actually implement legislation and lead prevention measures, etc. Thank you.
Thank you so much. Then another question that we had was, what about the long-term snowball effect of a large-scale incident on other services such as post-burn scar management? So I don't know who wants to take that one.
Well, of course, all these, we've talked more about the immediate distribution and aftercare and the acute care. But of course, there's a long-term care for all of these burn patients. And as with any of our burn patients, this also is the case in disasters. So I think I don't think I can give a like a definitive solution to this, but I think it's super important that when you do this structural planning on each stage or each level, the aftercare or the rehabilitation also needs to be part of your planning. You should not forget it. So I think that's a wise reminder from the audience.
Yeah, thank you so much for that. Another question we had from Roman Lefloc was, and I think Tom addressed it to a degree, with regards to the prevention of scooping post tanker explosion. He's asking, why is it still happening? Like, do you have any ideas why it's still happening? And I think you spoke to it about the economic situation, Tom. That's why people still risk their lives to try and scoop post a tanker explosion. So do you have any other thoughts?
Yeah, I mean, I think it's a very it's a good question, and it's easy for us to sit in more well-resourced places with the knowledge of what can happen because we're aware of it. We work in the sort of field of burns, to think, why on earth are people doing this? Are they, can they not understand what might happen? And I think the reality is, I don't know is the answer to that question. And for me, that is what's really important about that is, rather than trying to impose any sort of prevention activity without thinking it through, the most appropriate manner is to actually speak to people, and whether that's through clinicians doing that, or social anthropologists or medical anthropologists or researchers, to go and actually talk to people and find out what is their knowledge around what might happen at a tanker crash, because we may find out that there's actually a very different solution from what we think, because we already have that knowledge. So I think it's important to do research in that area, and to say, rather than, we tend to often resort to the same thing. Oh, let's put up some posters, let's announce something on the radio, let's do this, let's do that. I think the important thing is to go to the people who are actually likely to be victims of this type of event and speak to them and ask them, and do research in that field to try and identify what the key pointers are. And it's only by doing that we will find what is the most appropriate way to try and prevent these horrific specific type of mass casualty event.
Thank you so much. And I like the fact that you say we should speak to people, not at people, because we also need to take ownership for some of the problems that we are facing. So I would like to thank Stian and Tom for the very informative and sharing your knowledge during the Q&A session. And then I will hand over to Lucy.
Thank you very much, Ethel. I'd also very much like to thank Ethel, co-chairing this session, and the rest of the steering committee for working so hard together to bring this week to fruition. Thank you, Tom and Stian, and also Nikki and Richard for fabulous presentations. Thank you all for attending this webinar. We'll close this one today. If you would like a certificate of attendance, you can scan this QR code, and that will take you to a feedback survey. So please give us your feedback. This really helps us when we're planning for World Burns Week next year. And really, World Burns Week depends on engagement from around the world. So thank you very much indeed for scanning this QR code, filling out the feedback survey. Please catch up on the videos of the other webinars that were held earlier this week. There's one more webinar at 0100 GMT tomorrow morning, and then day 5 tomorrow focuses on survivorship, preventing isolation through community. So we very much urge you to attend that one. And we also encourage you, please, to run your own local activities and tell us about it. It's fantastic as a steering committee to find out what's going on around the world. It can be an individual event or a march, whatever you would like to do, but we have an interactive map on our website, and so you can log what local activity you've been up to so that we will know, and we can put pictures of that on our website. Thank you all very much indeed. Thank you, our panelists. It's been a fabulous session, and please save the date for next year, World Burns Week, the 2nd to the 8th of November 2026. We hope every year that this will grow and grow. Thank you very much indeed. Goodbye.